I'm O'Shaughnessy. I'm at Baylor University Medical Center, Texas Oncology, and U.S. Oncology in Dallas, Texas. For a woman who's been newly diagnosed with breast cancer, or a man, and it appears from their history and physical examination that it's likely that they don't have overt metastatic breast cancer, but yet they have a breast cancer that's somewhat serious, larger, for example. Perhaps there are clinically positive lymph nodes on physical examination in the axilla, for example, and there is a possibility that there could be metastatic disease, meaning frank disease that could be seen in one of the vital organs distant, the liver, the lungs, the bones, for example, on scans. The question is, should we be obtaining scans, CT scans, bone scans, PET scans in patients who are presenting with newly diagnosed breast cancer? Now, the first thing to say, I think, is that our American Society of Clinical Oncology, ASCO, and our NCCN guidelines do not recommend that we obtain scans on patients who are newly diagnosed with breast cancer because of the reason that the vast majority of the time, it does not impact how we will treat that patient. Now, that's different if someone presents with a large cancer, lymph nodes clearly positive, and the woman or man has symptoms. They are having bone pain, cough, for example. That's a very different matter. It's very important to obtain scans because there's clinical concern for metastatic disease, but that thankfully is very unusual. And so all of the clinical trials we have, pretty much all of them, over the decades where we're giving chemotherapy, endocrine therapy to cure patients of disease, did not get scans. And so we don't need the scans in someone who's otherwise asymptomatic, and we're going to get laboratories as well before we give chemotherapy. And as long as the liver function tests, for example, are not concerning and they don't suggest liver metastasis, or the alkaline phosphatase is not elevated, suggesting bone metastasis, and the complete blood count, the CBC, is not low, suggesting potential bone marrow metastasis, as long as the patient has no symptoms and the laboratories are good and the physical exam does not suggest metastatic disease, scans very, very rarely contribute to the management and outcome of that patient. Now, that's our national guidelines, is because there's just no proven benefit from it. Now, on the NCCN guidelines, it does give the option of a PET CT scan or other scans for patients with stage 3 breast cancer that's locally advanced. This is a larger volume of cancer in the breast, in the axilla, where there could be a possibility that scans could change management. For example, PET CT scans could pick up metastatic disease, which, if biopsied and proven to be metastatic disease, would change therapy. The other place that PET CT scans sometimes can be of benefit is in a woman, again, with stage 3 breast cancer, a locally advanced breast cancer, clearly positive axillary lymph nodes, for example. Sometimes the PET CT scan will pick up involvement of other nodal beds, for example, down the breastbone, the internal mammary lymph nodes, or above or below the collarbone in the infra or supraclavicular lymph node area. And this could be potentially helpful to the radiation oncologist when it comes time to fashioning the treatment plan for radiation. So there is a little bit of a gray zone, if you will, for the stage 3 patient. In my own practice for stage 3 breast cancer, I do try to get a PET CT scan. If the insurance company does not support that with reimbursement, then I will go ahead and get CT scans and bone scan, looking for evidence of metastatic disease or areas of other nodal involvement that may help us down the road with radiation therapy. But in stage 1 or stage 2 disease, the chances, fortunately, of finding frank metastatic disease or other nodal beds involved is very, very low and is very, very unlikely to change patient management.